Hi, this is Dr. Schmoe from the Functional Neurology Center, and I'm going to be talking about an area of the brain called the nodulus, which is a very midline area in the cerebellum that helps integrate and detect gravitational load on your body, and it really helps integrate with your balance systems, velocity storage, gravity detection, whether your brain knows whether you're translating or you're tilting, and it fires up into areas that control your eye movement function as well as vestibulospinal reflexes. So it is an area that's super vital. It's important with concussion and dysautonomia and movement disorders and trauma and injuries. This area of the brain, which is very primitive, always gets affected, I've seen, in more complex neurological cases. So the system of rehabilitation that I've integrated is called the Nodulus system. It's a technique system, and it integrates multiple different types of technologies. It's a way of thinking, and it's a way of assessing the nervous system and developing very precise strategies to go after that very old primitive area in the vestibulocerebellum. So it's a hidden gravity sensor in your brain. Most people think of balance as something handled directly by the inner ear or perhaps by vision, but buried deep within the cerebellum lies a small but vital structure, the nodulus, and that helps us know where we are in relationship to gravity. The cerebellar nodulus is part of the vestibulocerebellum, and it acts as a critical node for detecting tilt, integrating vestibular inputs from the otolithic organ. So in your inner ear, you have otoliths and you have canals. That otolithic area fires into the vermis of the cerebellum, which has the nodulus, a very specific area, and that area is vital for adjusting postural reflexes, integrating reflexogenic movements of the spine, firing down through vestibulospinal integrity. And with our system, we've built it around retraining these gravity detection networks using cutting-edge assessment, rehabilitation strategies for concussion, dizziness, dysautonomia, and high-performance needs. The nodulus, it's a small lobe. It's very midline, so you can think of the cerebellum as having the vermis, and then if you go even deeper down, you have the nodulus, and then outside of the nodulus, you have the flocculus and the paraflocculus. They're just names. But that nodulus area is very important for gravity detection and static tilt, really just like slow types of movements compared to the flocculus and paraflocculus that are more involved with these kind of quick vestibular ocular reflexes. So we have a variety of strategies that we use to target that area of the brain. And I think that if you target that area of the brain and get it balanced and steady, it'll really integrate with the autonomic integrity to allow you to know and perfuse up to your brain and activate different networks that help you detect that gravitational load before moving on to more complex strategies, that might involve, moving your head fast or moving your eyes really quick. So we do a lot of really cool, innovative techniques where we're moving people really slow. So we got to figure out, do we move you really slow, or do we move you quick, or do we move you fast? Sometimes people have a really hard time with just detecting slow movement, and then you go and you move them fast and they're fine. So we can actually use spillover from moving people fast to help their slow system. And that's what we're trying to figure out with our nodulus system and our technique is, do we do slow? Do we do fast? All right, where do we start? And that's where we start with our system and this kind of understanding of what's called velocity storage. So one of the nodulus main important contributions is velocity storage. So your inner ear has a system that helps you detect angular rotation, translational movements, but that has to fire into the brainstem, and then that fires up into the brain to what we call, perseverate the system, to activate these networks in the brain, to fire up into your parietal insular vestibular cortex to build appropriate maps of where you are in relationship to your world around you. So patients with triple PD, MDDS, people with VID, so visually induced dizziness, always have changes in these velocity storage mechanisms. So with our system, we're going to assess that. So we're going to have people just close their eyes, see if they feel steady, add in different tilting of the body, see if they feel rocky or floaty. Patients might respond different and feel, changes like they're moving up and down, or they might feel a little off when they're rolling. And based off those symptoms of what they're feeling can help us figure out, is this more like vestibular migraine or is this more triple PD? So with the system, we can actually kind of target and figure out, well, what's the mechanism? What's going on here? Is this visually induced dizziness? Is it triple PD? Is it vestibular migraine? And then there's different therapeutics that you can use for, what the diagnosis is. I love this picture, but this picture looks at the different networks that fire into the vestibular nuclei. So you have your vestibular input, so otolith afferents and semicircular canal afferents. And then you have the cerebellar inputs into the vestibular nuclei. So flocculus, paraflocculus, nodulus, and uvula. And look at that, we got the neck and the proprioception input via, pathways from the cervical nuclei firing into the vestibular nuclei. And that's more of like a bottom-up approach, and everything then is firing down from the brain through ocular motor networks into the brainstem and cortical networks, firing down, more of this top-down approach. So we do take into account mindfulness with the system. We do different types of electrical stimulation, so trigeminal nerve stimulation, different gait strategies, balance strategies that are cool, that are usually a little bit different than your typical types of vestibular exercises. And then we're doing very specific optokinetic training and different eye exercises at different angles depending on changes in your translational VOR. So, say if we take your head and you're good here, and then we translate you back into the left, we might see what's happening with your eyes moving out into the right. Are you off with convergence? Are you off with divergence, moving in that direction? And we utilize different strategies to move your eyes through that plane of movement to recalibrate those translational reflexes. We use some different technologies in the system. We use the Ciatrix chair. We use the M6 chair, which is basically a translational chair. We use a device where we can translate people down hallways. And then we'd use different technologies to work on quick eye movements at different depths. And then we do really slow movements. And then we also have people move really, really quick, right, with activation with electrical stimulation. So it's a system that I've put together that integrates information that we know, that I've helped a lot of people, get better with more complex visual vestibular integration problems. And we've had people that have flown from all over the world to come work with us here in Minnesota. So if you feel like you're looking for something different, something new, if you're stuck, feel free to reach out at thefnc.com. Again, this is Dr. Jeremy Schmoe, board-certified chiropractic neurologist, and we're located in Minnetonka, Minnesota.